Dear friends, welcome to the show Talk with Your Doc. I am Dr. Prashant Jani, and our guest today is Dr. Ayaman Hassan. He is a neurologist at Thunder Bay Regional Health Science Center. And our topic for today's discussion is epilepsy. Epilepsy is a quite common disorder, and statistics say that about 360,000 patients are affected with epilepsy in Canada alone. And worldwide, 1 in 100 patients are affected with epilepsy. So it's a quite common disorder, and it not only affects one's personal health, but it has impact on social and economic aspects of the society as well. And hence it is very important to know about epilepsy, what are the causes, how to prevent it, and how to treat it effectively. So Dr. Ayaman Hassan is going to guide us for the same. Thank you, Dr. Hassan, for coming to the show.
My pleasure. Thank you for having me.
What is an epilepsy?
Epilepsy is spontaneous recurrent seizures. So it's basically if a person has 2 unprovoked seizures more than 24 hours apart, this satisfies the clinical diagnosis of epilepsy, which is primarily a clinical diagnosis.
So what is the difference between a seizure and epilepsy then?
So seizure is paroxysmal discharge of neurons that can be provoked by many things, like alcohol withdrawal is one reason. Sometimes some medication like antibiotics and others can provoke seizure. Low blood sugar in diabetic can lead to a seizure, but not epilepsy. So epilepsy is when there is unprovoked seizures.
Unprovoked means without any cause, underlying cause probably.
Without any metabolic cause. It could be, the cause could be from the brain. Like a brain tumor can lead to epilepsy, but not seizure.
So how long a seizure lasts and how long an epilepsy lasts?
It doesn't matter. Both of them can last the same time. And the duration of the seizure depends on the type of seizure. So like if we classify the seizure to big categories, the 2 main categories would be the generalized seizure, in which there is a paroxysmal discharge from both hemispheres at the same time, and the pacemaker is in the brain stem.
Right.
While the focal seizure starts in one side and one area, localized area in the brain to the one side, to the one hemisphere, and then spread from there, could be end up with a secondary generalized seizure as well. So the generalized seizures are more like the more common ones are the grand mal seizure or the generalized tonic-clonic seizure, where the patient have this tonic spasm followed by the clonic one. The eyes are rolled back, and it can take few minutes, most of the time less than 2-3 minutes, but some people may have a longer seizure like 5 minutes.
So if somebody has a seizure, does that mean he has an epilepsy?
No.
No, right?
So
how do you differentiate it?
Only if it's unprovoked. So 2 unprovoked seizures more than 24 hours apart, because some people may have more than 1 seizure in 24 hours. We don't count this except as 1. And then if there is more than this, more seizure after 24 hours, this is when this patient satisfies unprovoked. This would satisfy the diagnosis of epilepsy.
So what happens when somebody has unprovoked seizure? Like we are just sitting and then somebody starts getting a seizure. Is that what happens, or?
It could be. It depends. Like some seizure come with warning or aura, like the focal seizure, depending on where it's coming from. Like people with temporal lobe focal epilepsy, which is a common type, would have uprising epigastric sensation, like something abnormal here that goes along their chest before. They may have a blank stare followed by some stereotyped movement like lip smacking or rubbing their hands, and after which they may feel they are back, confused a bit for a while, but they may require to sleep for some time, and then they are back to normal. So it depends on the type of seizure, like the absence seizure or the petit mal, which is one type of generalized seizure. The patient, for a second, like I'm talking to you, and then I may have blink twice or do some movement around my lips or do nothing, and then I'm back and I can continue talking, and this lasts only for a few seconds. Most common in children, and the teachers are very good. They can spot it and make the diagnosis most of the time.
So can one type of seizure, like which is focal seizure, progresses to generalized seizure?
Yes, this would be a secondary generalized seizure. So like it may start in one area of the brain and then move from this area to the brain stem, where it lead to this generalized seizure, and then it goes to both hemispheres at the same time. So a patient like the one we were describing, who would start with this blank stare, some automatic movement like a lip smacking, and then they may end up, if it's coming, let's say, from the left side of the brain, this will affect them to go all the way and start turning the head and maybe lifting the arm on the contralateral side, and then it becomes a generalized. So the description and semiology of the seizure, from the time it starts until the end, is very important. And the good thing is, before we used to bring those patients to monitoring, now with the cell phone becoming available, people can take a video clip of the seizure, and if it's from the start, it's very good and very helpful to make the diagnosis.
Right. So it is seen in all the ages and all the genders, or?
So the generalized seizure have two peaks. The first peak is in the first few years of life, mostly in the first year, and then the second peak later in life, like after age 65 or so.
Okay.
And this could be the generalized seizure, the idiopathic one, that it may have some genetic background, and we can't find any cause in the brain, and there is no warning prior to this type of seizures.
Correct.
Yeah, go ahead. You wanted to ask something?
You say generalized seizure has two peaks, and do you see?
Yes.
Do you see in all the genders and all the ages? Or?
Yes, I don't believe that there is any difference between male and female when it comes to epilepsy.
So what is the underlying cause? As you mentioned that it can be caused by the brain tumor. What are the other causes for the seizure?
Like in adults, brain tumor, scar from head injury. That's why it's important to get any inquiry about significant head injury. Sometimes febrile convulsion in children, which can happen between 6 months of age and 5 years, in relation to fever, can lead to a scar in the temporal lobe, and later on, after, like in the late teenage, can lead to some form of complex partial seizure or this type of focal seizures.
Is there any genetic composition or attachment?
Mostly for the generalized seizure, yes. So in idiopathic generalized epilepsy, which comes either with the grand mal seizure, the generalized tonic-clonic, it's the same thing, or the absence seizure, or the myoclonic seizure, where people do not lose consciousness even.
They have a genetic history?
This usually has more, but even for the focal, there are few families that have genetic background in there and responsible for their seizure.
Very interesting information. We'll continue our discussion. We'll take a short break, and please stay back for the next part. Thank you. Dear friends, welcome back to the show Talk with Your Doc. Our guest for today is Dr. Ayaman Hassan, and we are talking about epilepsy or seizure disorder. Dr. Hassan, we were talking about different causes of seizures, and one of the reasons we talked about is trauma. What sort of trauma can cause a seizure?
Of course, if it's a severe head injury, this most probably will lead to a seizure down the road. Not necessarily leading to any brain like a subdural or extradural bleed, which is bleeding outside the brain between the tissues, but even a bruise on the brain or a scar from previous head injury can lead to it.
Sports-related injury probably?
Could be too, but it's not that common in a sport-related injury because of all the protection devices they use and the helmet and things that they are using. But it may lead to also as well as to seizure disorder. But most commonly, the one that you would see with motor vehicle collision and these kind of things.
Right. So once somebody has epilepsy or seizure disorder, then he goes to a doctor probably. Then what are the investigations done to diagnose this?
The standard investigation in most cases are an EEG, electroencephalogram, and this is a way where they put electrodes on the surface of the brain to record the electrical activity of the brain. Of course, this is not as good as EKG because the heart is very close here, but inside, to get any information through these two thick bones of the skull is very difficult. So you need a lot of filters, and you need a longer recording that take about at least 20 to 30 minutes of recording, other than applying all these electrodes and taking it off. The other thing would be neuroimaging, and the best here would be an MRI scan. because you want to look at the temporal lobe and the inner part of the two hemispheres, including the frontal lobe or the occipital lobe, and the MRI give you a better images with
It
regards
can
to
give
resolution.
information whether there is any damage or trauma or tumor or bleeding
or a small
something.
scar from something else.
Yes,
or whatever.
yes.
Yeah.
Any blood tests required to be done?
Not to make the diagnosis, but of course, when the patient arrives with a seizure for the first time, they run this metabolic workup to make sure he's not low on calcium or magnesium or blood sugar that may be the cause of seizure, and this would be a symptomatic seizure secondary to this metabolic disorder.
If somebody gets the epilepsy or seizure in the pregnancy period, what are the precautions they are supposed to take?
They are non-epileptic before, or this is the first seizure?
Maybe they are non-epileptic.
Okay. So, like before pregnancy, the advices are we need to counsel the patient before getting pregnant to make sure that they are on the anti-seizure medication that has the lowest risk of congenital malformation. The second advice is usually to start folic acid, which most pregnant women use, but they start on this folic acid after they know that they are pregnant. However, in epilepsy, because of being on medication, we advise them once they stop their contraception or they are getting ready to get pregnant to start on folic acid. And instead of the 1 milligram that is frequently prescribed, we advise 4 or 5 milligram. So to start before pregnancy. They found out that many of the anti-epileptic related adverse event or congenital malformation happen in the first 21 days. So it's very important to start before getting pregnant.
And these anti-epileptic medications, do they affect the baby in the womb?
Yes. So congenital malformation, the highest is with one of the medication called valproic acid, which we prefer not to use in female in the childbearing period. The least are the newer medication. This include lamotrigine, levetiracetam. So there are pregnancy registry that started in many countries. There is North American one, Australian, UK, and from all this pregnancy registry, we are able to collect information and know which medication causes more problem than the others. So older medication, valproic acid, carbamazepine, dilantin, or phenytoin, causes higher risk compared to others, while lamotrigine, levetiracetam from the newer one causes less.
So one has to be monitored while taking these medications during the pregnancy, right?
Yes.
Now, what sort of preventive measures one can take to even before somebody gets the epilepsy or seizure episode? Is there any day-to-day precautions one has to look
in an epileptic patient, someone who's known to have epilepsy? Yeah, we always advise them for sleep. Like adequate sleep is very important. Sleep deprivation is one of the ways that we use to trigger seizure and to trigger changes in the EEG. And if the routine EEG electroencephalogram is normal, then we ask for sleep deprived EEG. The other thing is the flashing light. So that's why again we use photic stimulation to trigger seizure, which is effective more in what we call photosensitive epilepsy. Before, it was even video games and many other things were a problem until I think 1994, when a teenager, like 14 years old, was playing one of these video games and he died because of a seizure. Shortly after, in 2000 in Japan, during Christmas time, they were showing one of the Pokemon episode, and 700 plus children ended up in the hospital. Half of them had migraine and half of them seizure. And they started looking what is the cause, and they found that certain colors, like I think the one in Japan was red color, epoch more than 2 seconds, and whatever. So they started to collect this information and put filters depending on the country. And if you have any of these video game now, you will see all these stamps that show that it is approved by this country to be used. And these are very strict criteria to eliminate anything that may trigger a seizure.
So those games, colors in the games stimulate the seizure?
It's like video games, like different types, whatever, Xbox or whatever, and all of them have all these kind of things. So starting from 2000 on, people start to look carefully into this matter, and I don't believe that there is many of these available. But still, The problem with video game now is more than this, is being sleep deprived.
Yes.
So, like the teenager, whatever, they continue to play the whole night and then they don't sleep.
Absolutely.
And they end up with seizure because of this, more than the games itself. Of course, if the room is too dark and there is no light behind, if they are close to the TV,
Yes.
It's another problem. Before, like the older TV, where there is this alternating fields, like
Yes.
the dark and white field, if you remember from the old days,
Yeah.
which we don't have anymore now, like after the plasma and the
LEDs
LCDs and
LCD,
LEDs
yeah.
and all these kind of things.
Yeah.
But this one used to, like this frequency, and in Japan, don't forget, they use a very high frequency. Like here, we use 50, 60 hertz.
Right.
They use their 400 or so.
Wow.
So that's why it was very irritating, and it leads to more of this seizure. But this part is, we don't have to talk about. You don't have any of these TV
Yes.
sets anymore now.
Yeah. That's very interesting information. We'll continue our talk in the next part. Please stay back for the last part. Thank you. Welcome back to the show Talk with Your Doc, and our guest today, Dr. Ayaman Hassan. We are talking about epilepsy, and we were talking about sleep deprivation and long-term use of monitors throughout the night can cause possibly seizure or epilepsy. So adequate rest is very important part of the sleep. Any other precautions we need to take to prevent epilepsy?
And again, when we talk about sleep, it's sleep during the night. So
Yes.
like we always advise them, please sleep somewhere between 12 midnight and 6 a.m. Then if you wake up early and you have to do something and you want to take another nap during the day, fine. But saying I sleep 8 hours, but I sleep from noon, like 12 to 8 p.m., this is not good enough. It's not the same thing.
Right. So now, what are the treatment options in epilepsy?
There is the medical treatment, and it's good now that before we used to have only like 3 or 4 medication until maybe the 1980s, and then newer medication start coming out every day, and now we have too many medication that has less side effects compared to the older medication, and at the same time has as good efficacy to control the seizure.
And all these medications are safe and with less side
the
effects?
safety are much better now with the newer medication. So the adverse events fell from 31 to 7% with the newer medication, and it's most of the time tolerable, not as with the older medication that people used to have regular complete blood count, liver function test, and medication level every 6 months.
So somebody who has the epilepsy, he or she has to take the medication throughout the life?
No, so it depends. There are some syndromes that you know that it will end by certain age. Like children can have a benign form of what we call benign Rolandic epilepsy, which is focal seizure that start at certain type of area of the brain. And even if you don't treat this one, still it's okay, because they have this seizure, but they are still able to function. They don't lose awareness, and by age 14, most of this seizure will go away.
Yeah.
So whether to treat or not, it depends. But when it comes to other forms of epilepsy, like generalized epilepsy, let's say, or focal epilepsy, we know that with the first treatment, 49% would respond to the first monotherapy using only one single anti-epileptic medication. Another 13% will respond to switching. So the total of people who are responding are about 62%. And then we are left with 30% who are intractable to medical treatment and may require either using more than one medication or refer them to epilepsy surgery program.
Yeah, so please tell us about this surgery. Who needs the surgery?
So people who have intractable epilepsy or drug-resistant epilepsy, and it's very simple. Those who fail to anti-epileptic medication use adequate dose for adequate time. If this happens after 6 months, this patient is deemed drug-resistant epilepsy, and they need to go to one of these epilepsy surgery program for evaluation.
So what do they do in the surgery?
It depends. So if this is like a scar, like the most famous one, and the very early surgery for epilepsy actually came from Montreal, here from Montreal Neurological Institute by Dr. Pinfield and his co-worker. And the first study that supported the surgical treatment for epilepsy as a randomized controlled study where they had surgery done on people like faster than the usual wait time, and they found that there is much benefit of doing this. This was for temporal lobe epilepsy, and this came from London, Ontario here in 2000, published in New England Journal of Medicine. So if there is an area like what we call mesial temporal sclerosis, this is scar tissue inside the inner part of the temporal lobe on one side, this is very amenable to surgery. So
they remove that area?
They remove this area. Sometimes they remove a larger part of the temporal lobe, or after checking for where the memory is, where the speech is, to make sure that nothing happened. Even people who have surgery on eloquent cortex, where this cortex has a very important function, and if they do the surgery, the patient may lose some of this function. There are some surgical procedures that can be done non-resective, but they do a subpale incision that lead to control of seizure, to cut the circuits between these. So there is many options that can be provided from a comprehensive surgery, epilepsy surgery program.
So this surgery, is there any risk associated with the surgery, and is the risk of surgery outweighs the risk of having epilepsy?
Excellent question. And this is what they did in this study that came from London, Ontario in 2000. They showed that the people, the risk of complication with surgery was much lower than the people who continue to have intractable epilepsy, because the risk of morbidity and mortality was like 10% on those people who had later surgery compared to earlier surgery, where they had much less rate of complication and problems.
So surgery is safer probably than having intractable epilepsy for a long time.
Yes, and again, the medication, effect of medication when they are on multiple doses of the medication, the seizure itself affect their cognition. So if those people are in their 20s or productive years of life, they end up being unable to function, unemployment, the social stigma, all these kind of things. If they have a successful surgery, which works in 60 to 70% of cases in some of the very localized seizure disorder, they are back to normal life. They drive, they stop anti-seizure medication after a while, and they do go back to their normal routine.
So if somebody doesn't take surgery as a treatment and has long-term intractable epilepsy, can a person die with epilepsy?
Yes, so there is what we call sudden unexplained death in epileptic patient, SUDEP, SUDEP. And this can happen in 1 to 9 out of 1,000 patients with epilepsy. So it doesn't look like a high percentage, but you can't apply statistics on one person. So
it can cause death.
Yeah.
And cause of death is?
It's unknown. There is many theories, but we don't know what exactly causes the death in these cases.
Right. So whom should we one contact for the treatment of epilepsy? Is it like neurologist or family doctor?
It could be, but family doctor, nurse practitioner, internist, neurologist, epileptologist.
Who is epileptologist?
Epileptologists are neurologists are so specialized in epilepsy that most of them would work in an epilepsy center. So in Ontario there is 6 district epilepsy center where they can provide the diagnosis and the counseling and everything related to surgery. But if the patient needs to go to have surgery done, then they are referred to 2 centers here in Ontario, one in London, Ontario, and the other one in Toronto. And this is what the Epilepsy Implementation Task Force mandate was, to work on the neurosurgical epilepsy capacity, to make sure that the patient who require treatment would receive it timely and without delay.
Last question, if somebody has epilepsy, can he or she drive a car or play the routine sports, or what sort of precautions to be taken?
Yeah, so like I told you, 62% of epileptic can be effectively treated by medication, and those people who are treated with medication after being seizure-free for 6 months, they can live a normal life. They can drive, they can play sport, they can swim unattended, they can do anything. The risk of seizure after this is much lower than during the time when in the first 6 months after
For 6
having
months,
the
they have
seizure.
to take a special precaution probably and not to drive or not to play the sports.
Yeah.
That's very interesting. Thank you so much, Dr. Hassan, for giving so much information.
My pleasure.
Thank you, everyone, for joining the show.